Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
This program is presented by Medscape Education Global.
Hello, everyone. My name is Jörn Schattenberg. I'm a professor of medicine and director of the Department of Internal Medicine 2 at the University Medical Center in Hamburg, Germany. And I'd like to welcome to this program entitled Emerging Therapies for MASH from Theory to Clinical Practice. Now, this would not be possible without two esteemed colleagues and experts in the field, and I'd like to introduce you to both of them, taking a second, giving them the opportunity to speak up at this time. Naeem?
Thank you, Jorn, for organizing this program. I'm delighted to be here. Naeem Al-Khoury, I'm the Chief Medical Officer at Summit Clinical Research and the Director of the Steatotic Liver Disease Program at the Clinical Research Institute of Ohio.
Great, thank you. Pass it over to Professor Thiele.
Thank you so much, Jan. My name is Maja Thiele. I'm a professor of hepatology at the Center for Liver Research in Odense at Denmark and University of Southern Denmark. Very happy to be here.
Thanks both for joining today. The task is to go and talk about MASH. As you're all aware, MASH is a progressive liver disease that's caused by inflammation leading to fibrosis and detrimental end-stage liver disease for patients. It's one of the leading causes of liver disease worldwide. And if it's left untreated and unaddressed, it can lead to liver cancer, liver failure with transplantation, and death. For that reason, early diagnosis is crucial. Naeem, can you tell us about why it's so important to recognize and treat MASLD early?
Yeah, that's very important to understand that MASLD is a spectrum of diseases. It starts with what we used to call simple steatosis or MASLD. This is when you have steatosis but no significant inflammation or liver cell injury. This can progress to MASH where you have steatohepatitis. Typically, you see ballooned hepatocytes and inflammation in addition to steatosis. Early MASH is defined as having MASH with no significant fibrosis. So stage 0 fibrosis or stage 1. The patients that we really want to identify within the spectrum of the disease is patients with MASH and what we call significant fibrosis or stage 2 or higher. So stages 2, 3, 4, because these are the patients that can progress to cirrhosis and its complications. And we have several studies showing that patients with stage 2 or higher, they have a higher risk of severe liver disease. And also, more importantly, they have higher rates of dying from liver disease, so their liver-related mortality increases. Now, historically, we used to rely on a liver biopsy to determine the fibrosis stage and see where the patient is within that spectrum that I mentioned. But today we can actually rely on non-invasive tests or NITs to determine the severity of the disease. And these can be divided into serologic tests, and that can be further divided into simple scores, such as the FIB4 score, which is the most widely utilized one. This includes simple markers like AST, ALT, platelet count, and the patient's age, and you get a calculation. If it's less than 1.3, this typically indicates lower risk of having significant fibrosis. More than 2.67 indicates high risk. We also have a more complex serologic tests, including the Enhanced Liver Fibrosis Test, or ELF. This has 3 biomarkers in it, and you get also a value. Values over 9.8 typically indicates advanced fibrosis and risk of progression to cirrhosis. And then we have several imaging tests that rely on measuring liver stiffness as a surrogate for liver fibrosis. The most widely utilized one is called vibration control transient elastography, or VCTE. You typically get two values. One is the controlled attenuation parameter that can quantify the amount of steatosis in the liver to diagnose MASL. And then you have also your liver stiffness measurement in kilopascal units that can identify the stage of fibrosis. And typically, having a liver stiffness above 8 kilopascal indicates the presence of significant fibrosis. Now, recently, especially in the United States, we had resmetirom approved by the FDA in 2024, and recently we had semaglutide also approved. So we developed criteria to select patients for pharmacologic treatment. These are the patients that have MASH with stage 2 fibrosis or higher, but we do not treat cirrhotic patients at this point with these agents. So to do this, we utilize non-invasive tests, and we divide patients into three zones or categories. One is, we call it the green zone, where treatment with the pharmacologic agent is indicated, and we utilize different non-invasive tests. So, for example, with transient elastography, values of liver stiffness between 8 to 15 kilopascal indicates that the patient is a good candidate. And we have similar values for MR elastography, which is another imaging test to stage fibrosis. We have similar values for the enhanced liver fibrosis test. We then have what we call the red zone, or the do not treat zone. This is when we don't recommend treating because the patient potentially has cirrhosis. So, for example, with liver stiffness, if the value is above 20 kilopascals, we say do not treat. And finally, we have patients in the yellow zone where you can treat with caution. And these are patients with liver stiffness between 15 to 20 kilopascal, where you have to make sure that you look at other variables, make sure the platelet count is completely normal, make sure you have abdominal imaging, rule out the presence of splenomegaly or any nodularity in the liver contours. So this is how we think about who are the patients we need to identify and how to select them for pharmacologic treatment. So back to you, Jon.
Great. Thanks, Naeem, for that overview and the exciting news that you've been treating patients with medicine actually for over a year now. And the good news is, obviously, EMA has approved resmetirom for the treatment. I'm going to be digging into the data and the pivotal trials a little bit later. For the moment, I'd like to actually come back to you and think about, in your clinic, in your waiting room right now, which patients are the ones at the highest risk of developing end-stage liver disease, and therefore might be the ones to be treated and managed. Remember, I think one of the very well-defined treatment goals is to avoid cirrhosis, to avoid cancer and transplantation. Next, let's talk briefly about the mechanisms and goals of MASH treatment. I think it's important to realize that the liver disease does not exist in an isolation, and as such, the treatment goal is defined in different categories. A very important category is to improve the overall metabolic syndrome, which is the underlying condition. Now, with a new name change, that's even recognized in the name metabolically dysfunction associated steatotic liver disease, by improving the body weight, by improving glycemic control, arterial hypertension, dyslipidemia. These are important treatment goals in our patients. But on the other hand, we do have liver-directed treatments available to lead to MASH resolution and fibrosis regression. We're going to be discussing that data in a little bit. In the long term, of course, we want to avoid major adverse liver outcomes or major adverse cardiac events, MALO and MACE, which have the biggest impact on cost and patient lifetime. We're now entering a new era of targeted therapy for treating adults with MASH and moderate to severe fibrosis equivalent to the histological stages of F2 and F3 disease. The first class is the thyroid hormone receptor beta agonist, acts specifically in hepatocytes to alter lipotoxicity, decrease cellular stress, and improve cellular survival. It affects fibrogenesis through that mechanism directly in the liver, The other class of drug I'd like to discuss today are the incretins, the GLP-1 based therapies. Now, the difference here is that GLP-1 receptor agonists do convey their benefits through improving the metabolic dysfunction that exists in our patients and thus have indirect effects on the liver, but no targeted direct effects on the hepatic compartment. And that's important. For example, there are no GLP-1 receptors on hepatocytes in the liver. Talking about the label of the two compounds, resmetirom has been approved by EMA in June of 2025 and has received a conditional marketing authorization based on the high unmet need that's currently fulfilled. But additional data is still needed, and the study is currently ongoing. The FDA approval occurred a year earlier in March 2024, accelerated approval based on the improvement of the surrogates of MASH and fibrosis. For semaglutide, EMA approval is currently pending, but FDA has approved semaglutide for the treatment of MASH with F2, F3 fibrosis at a dose of 2.4 milligrams in August 2025, allowing for accelerated approval based on the study results. Let's discuss the clinical data in more detail. The basis for the approval of resmetirom was the Maestro-NASH study. This is a 3-arm study comparing placebo versus 2 doses of resmetirom, 80 and 100 milligram, in patients that were pre-selected based on the presence of at least 3 metabolic risk factors, elevated liver fat, and leading to a liver biopsy that was consistent with disease stages F2 and F3, and a NAS score that's an activity score consisting of steatosis, inflammation, and ballooning of equal to or greater than 4, and again, fibrosis stages F2 and F3. There was a subgroup of patients up to 15% with F1 that served as a subgroup for safety analysis. The primary endpoint in this trial was the improvement of liver histology defined as the resolution of MASH or regression of fibrosis at week 52, and the trial is currently ongoing with long-term outcomes monitored up to week 54. Talking about the baseline characteristics, I'd like to highlight that there was an average age of 55 years and a high prevalence of patients living with type 2 diabetes, light predominance of females in the study, median stiffness across the groups between 12.9 and 13.6 kilopascals, showing that these patients really did suffer from significant to advanced fibrosis, and this relates to a histological fibrosis stage of F3 in 60% of the cases. Now, talking about the dual primary endpoint at week 52, resmetirom in both doses was superior to placebo in improving both MASH resolution without no worsening of fibrosis, but also improving fibrosis by 1 stage with no worsening of the MASLD activity score versus placebo. And important for this type of drug, LDL improved by both doses versus placebo. And this drug was initially developed as an LDL targeted therapy, but has since then shown its effect in the MASH space and has been approved for that. Talking about NITs in the Maestro-NASH trial, we saw a decrease in liver enzymes over time. You can see that liver enzymes drop from an elevated almost into the realm of normal for ALT, AST, and GGT. And there's been data showing that sex hormone binding globulin SHBG as a marker of engagement is positively impacted by treatment. And now let's turn to the safety summary. The majority of patients, over 90%, reported adverse events during the study across all arms, including the placebo arm. Notably, serious adverse events were comparable between placebo and resmetirom, and importantly, also no major signals on fatal or major cardiovascular events that were different. So good news with a strong safety profile, and the most common AEs being reported by the treated groups being diarrhea, nausea, and vomiting. Semaglutide was trialed in the ESSENCE trial in patients with MASH and F2, F3 disease. So this is comparable to the Maestro-NASH trial. Similar definition based on histological entry criteria with the evidence of MASH, NAS score of equal or greater to than 4, histological evidence of fibrosis stages F2 and F3, and at least 1 point for lobular inflammation and ballooning and steatosis. Average age in the study was 56 years, so also a comparable composition, slight predominance of females, and a high prevalence of patients living with type 2 diabetes. The ESSENCE trial was a 2-arm study, and it consists of part 1 and part 2. So part 1 is the one I'm going to be reporting on, and part 2 is the currently ongoing long-term outcome study of the ESSENCE trial. So in part 1, the efficacy of the drug was assessed by serial biopsy being repeated at baseline and week 72 for a pre-planned interim analysis. And the primary endpoints, as I've just highlighted, resolution of steatohepatitis or improvement in liver fibrosis. Baseline characteristics, 60 to 70% with F3 fibrosis, median liver stiffness 12.9, 12.8 in the 2 arms, and an ELF score of 10.0. Overall, over half of the patients had type 2 diabetes in both groups. Turning to the primary endpoint, semaglutide was superior to placebo in both endpoints, resolution of steatohepatitis with an effective delta over placebo of 28.7% for the resolution of steatohepatitis, and a delta over placebo in the treated group for improvement of fibrosis of 14.4%. Side effects and safety are comparable to what's known for the class of incretins, very typically with an increase in nausea, diarrhea, constipation, and vomiting for semaglutide over placebo, but no additional safety concerns in the liver population. So turning beyond the 2 phase 3 trials that have reported positive interim results, I'd like to ask you, Naeem, what else is there on the horizon?
Yeah, thank you, Jorn. We have multiple promising agents that are being developed to treat MASH with F2, F3 fibrosis, and we also have new agents that are targeting MASH cirrhosis. I like to think about these new drugs as oral agents such as lanifibranor, which is a pan-PPAR agonist, so it targets PPAR alpha, delta, and gamma. And then we have another agent called denifanstat, which inhibits de novo lipogenesis, a specific enzyme in that pathway called FASN. We also have several injectable drugs, FGF21 agonists such as efruxifermin, pegozafermin, efimosfermin. They are in phase 3 trials or planning phase 3 programs, and they've shown great efficacy in phase 2, including the reversal of cirrhosis and going from stage 4 fibrosis to stage 3 fibrosis with efruxifermin in a phase 2b trial. We also have dual agonists and triple agonists that are in phase 3, including survodutide, which is a dual agonist for GLP-1 and glucagon, tirzepatide, which is a dual agonist GLP-1 and GIP, and retatrutide, which is a triple agonist GLP-1, GIP, and glucagon. So the future is bright, and hopefully by the end of the decade, we will have multiple agents to choose from.
Thank you, Naeem. And that's a lively field indeed. Many of these drugs with strong rationale to improve steatohepatitis and fibrosis and endpoints, I would say. So with that, let's turn to Maya Thiele. Maya, you're an expert on non-invasive testing and identifying patients, particularly at the population levels. How do you place the current guidelines in place in Europe in that context?
Well, I think first off, the guidelines from 2025 was a major effort, and a nice one indeed, combining efforts from the European Association for the Study of Liver in collaboration with the diabetes and obesity associations. So this resulted in a very extensive document that really describes and provides recommendations for the management of MASLD across the full spectrum. So I think 2 takeaway messages. that was changed in the 2025 guidelines compared to previous was first the incorporation of the new nomenclature for steatotic liver disease. So in this nomenclature, we as a scientific community across uh, several continents agreed that steatotic liver disease is really a spectrum from patients with a metabolic dysfunction as the primary driver of disease on one hand to patients where alcohol is the main driver of disease. And this places the evaluation of the cardiometabolic risk factors as one part of the spectrum, in addition to alcohol history and present alcohol consumption in the center of the diagnosis. So we are moving from away from the prior nomenclature, non-alcoholic fatty liver disease, which was both stigmatizing and not very precise because it only said what the disease was not, into a positive diagnosis of metabolic dysfunction associated steatotic liver disease. Um, and when we detect patients with MASLD, of course, listing the spectrum of cardiometabolic risk factors comes first, together with determining the presence of steatosis, of excess fat in the liver. Um, there's a small note to this, namely that in those with severe fibrosis and cirrhosis, the excess fat seem to move away when fibrosis progresses. So in those patients without fat but with evidence of severe fibrosis or cirrhosis, steatosis presence is not a mandatory part of the diagnosis. Now, as a next important step after establishing a diagnosis of MASLD is risk stratification. And in the current guidelines, preference towards the well-established test FIB4 that was mentioned earlier. So it's an indirect marker of fibrosis because it contains AST, ALT, and platelet count and age. However, it has proven to be, let's say, fairly accurate in terms of discriminating true negatives from true positives. So in those with a low FIB4 below 1.3, there's very small risk of a 5 to 10 year liver-related events, so progression to symptomatic cirrhosis, and there's little risk of having advanced fibrosis or cirrhosis. So in those patients, they can remain in primary care or in the population and be reevaluated every 1 to 3 years, while those with a very high FIB4 test should be referred for hepatology evaluation using more accurate diagnostic tests. And for those intermediate, we have some patented markers that Naeem kindly alluded to earlier, for example, the LF test, the ProC3 test, and other algorithmic tests that may be used. So after establishing patients with a risk of progressive fibrotic disease in the MASLD population, the guidelines move on to provide a management advice. And here we can distinguish between those with MASLD and obesity versus those with lean MASLD. So weight loss is really at the center of management in the majority of MASLD patients because the majority will have concomitant obesity. And even with fairly small percentage body weight loss, we see improvements first in steatosis, then in steatohepatitis, and lastly in fibrosis. So diet-induced weight loss is kind of at the center of this management. Another part of the recommendations is physical activity, very important to improve insulin resistance and muscle and bone health. And there's also nice recommendations for how to manage mass cirrhosis where nutrition needs to be adapted to the risk of sarcopenia. Another part is the pharmaceutical management. the MASH targeted therapies approved in the US and in Europe for those with severe or moderate fibrosis. But then there's the pharmacological options for the comorbid conditions, which increases the risk of further progression of liver disease, but also for comorbid mortality extrahepatically. And these are kind of three arms targeting type 2 diabetes control, dyslipidemia, and obesity. Again, important in the holistic management of MASLD patients.
Thank you, Maya. This was great. A very robust overview of current guidelines and management. Now, I know you've compiled a number of clinical studies, and I'd like to have them presented. Let's start with your study again, Maya, or your patient.
Thank you, Jan. This was a 58-year-old male, a high school teacher. He came to his annual diabetes control visit at his primary care physician. In this case, our high school teacher has arterial hypertension. He also has abdominal obesity and takes classical medications for metabolic dysfunction. And so the general practitioner noticed that our case had slightly elevated liver function tests, so nothing serious, which is normal for MASLD, but a ST-ALT ratio just about 1, slightly elevated GGT, and when combining ALT, AST, and platelet count, the FIB4 was 2.85, which is just above the high level threshold of 2.67, but still places this particular patient in a let's say yellow moderate risk group. And indeed, in this patient, we see a hyperechoic liver indicative of possible steatosis of 20% or more, but no signs of cirrhosis. So this led to further testing using some of the more accurate patented non-invasive markers after referral to specialist care. And indeed, in the liver clinic where I saw the patient, we did the ELF test, again, a direct marker of liver fibrosis combining 3 serum tests. The ELF test was moderately elevated of 10.2, so above the 9.8 cutoff that we usually see for advanced fibrosis. Liver stiffness, again, moderately high, 12.4. ADAPT score, which includes the new ProC3 marker, was 10, and the CAP value confirmed that this patient had steatosis. It was more than 300, which rules in steatosis. Finally, in our clinic, we also did the PES testing, which is a direct marker of past 1 to 4 weeks of alcohol use. It comes from the non-oxidative pathway of alcohol metabolism, so it is highly sensitive to past 4 weeks of alcohol consumption. It was not negative, so this indicated social drinking. So our recommendation to this man was to, if possible, reduce drinking to see whether this could lead to slight improvements of his liver disease. But I would classify this guy as having MASLD or maybe leaning in towards the MET ALD spectrum.
Great. Thank you, Maya. Robust presentation and assessment. So you did not mention liver biopsy, and I understand you're well able to stage that patient in the absence of biopsy. Would that be correct?
I think, yes, in this case, there's a very nice alignment in the non-invasive tests. And this is what I like with combining both the imaging-based or elastography-based testing, which measures the viscosity of the liver using either VCTE, point shear wave elastography, two-dimensional shear wave elastography, or MRI elastography, and then a blood-based markers, which assesses liver fibrosis from a different aspect. And when there are concordant results, then yes, I think we can fairly robustly trust the evidence that indeed this patient has advanced fibrosis or early cirrhosis.
Great. So thank you. Concordance of biomarkers in staging this patients with a significant to advanced fibrosis based on MASH, maybe some alcohol consumption. Thank you, Maya. Over to you, Naeem. You prepped the case for us too.
My patient is a 62-year-old Hispanic female with type 2 diabetes and obesity, presents with elevated liver enzymes, and there is a family history of her mother dying from MASH cirrhosis. The labs showed elevated ALT and AST at 71 and 65, respectively, a platelet count of 225,000. And in our, hepatology clinic, we obtained VCTE, and that showed significant steatosis with the cap of 371 and liver stiffness measurement of 12.4 kilopascal, and the FIB4 index was at 2.13. So basically, the liver stiffness is consistent with significant to advanced fibrosis. We obtained an ultrasound, and that showed a smooth liver with normal spleen size. So these are signs of the absence of cirrhosis. And this patient came to us on a stable dose of a GLP-1 receptor agonist to treat her type 2 diabetes. Despite being on a stable dose GLP-1, she still continues to have evidence of advanced fibrosis. So I think the first thing I want to highlight in this case is that we need to look at the entire picture. So first you look at the pre-test probability of having advanced disease based on clinical characteristics. So here we have an older lady, Hispanic ethnicity, which increases the risk of more aggressive disease, heavy metabolic burden with type 2 diabetes and obesity, family history of MASH cirrhosis complications. So already very high pretest probability of having advanced disease. Next, we look at our non-invasive tests, and these also indicate presence of significant and advanced fibrosis based on the liver stiffness and elevated liver enzymes, but also we don't see any evidence of cirrhosis. So this is, in my opinion, a great candidate to initiate pharmacologic treatment. And since the patient has been on a stable dose GLP-1 receptor agonist, I think the best choice will be to initiate resmetirom, which is typically weight-based dosing. Our patient weight less than 220 pounds, so the appropriate dose will be 80 milligrams daily. I want to highlight that in the Maestro NASH trial that you discussed briefly, about 15% of patients were on a stable dose GLP-1 receptor agonist, and they're initiated on resmetirom. So no issues there in terms of drug-drug interactions. Resmetirom can be added on top of GLP-1. And I think there is potential for synergy there, although we need more data, because GLP-1 receptor agonists target upstream, and they help with weight loss and improving insulin sensitivity, whereas resmetirom is considered liver-directed therapy, and it's shown promising results on reversing fibrosis. Now, once we start a patient on resmetirom therapy, it's very important to monitor these patients, and the way I monitor my patients is by measuring liver enzymes every 3 months in the first year. And we also like to assess with non-invasive tests after we start treatment at 6 and 12 months. And then after that, we decide if the medicine is working and we see improvement in the non-invasive tests, or if we need to think about alternative approaches.
Thank you, Naeem. Very straightforward and well taken. So your choice to combine a GLP-1 with a thyroid hormone receptor beta agonist, in that case resmetirom, in a patient that's been on stable GLP-1 is well made. And I do think this is a good decision to advance, to potentially affect his underlying disease that was present, albeit that GLP-1 treatment. Any comments or thoughts on the case, Maya?
I think it's very well put. There will for sure be mentally patients where weight loss is not the only effective intervention.
Yeah, or to add and use the synergy that you hinted at, Naeem. I agree. Additional data is needed, and that will be generated in the future. So thank you again for sharing your US perspective on drugs efficacy and use here. Dear colleagues, dear listeners, it's been a pleasure. Time flies. I'd like to conclude. We've seen data on the urgency to identify patients, particularly looking holistically at our patients, the entire the entire sum of metabolic risk in a patient that leads and drives liver disease. And after optimization of the metabolic profile, Professor Thiele has talked about current guidelines that recommend optimized management, including, of course, lifestyle and physical activity. Pharmacological treatments are available. I've shown and summarized two of the pivotal phase 3 trials that led to conditional approval by EMA for resmetirom based on the MAESTRO-NASH trial, and the positive phase 3 results on semaglutide that have led to FDA approval, but not EMA approval yet. And of course, then the practical cases. NITs can be used to identify patients today in the absence of liver biopsy once the diagnosis is established, and we can robustly identify the cases that would benefit from medical treatments. So with two MASH-targeted therapies in the US and one approved in the EMA region, available in Germany these days, I think this is good news for our patients, for care providers, and the future looks promising based on additional phase 3 programs that are running. With that, Naeem and Maya, I'd like to thank you for your presentations, this great discussion, very helpful insights from our colleagues from the US. Naeem, thank you for sharing that. I'd like to thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation, and have a good day.
This program is presented by Medscape Education Global.